Hello, my dear nursing aspirants. Welcome you all to the Master Nursing classes. Once again, I'm welcoming you all to the Master Nursing classes. So, fataфат, do join to the session and be completely active in the comment box and completely involved in the question discussion, concept discussion, and whatever the question I am throwing in front of you people, try to respond whether it may be a right, whether it may be a wrong. Don't sit silently. Okay, so be completely involved in the comment box, so then only something it will penetrates in your mind, right? So very good evening to everyone. Good evening beta, good evening, very good evening to everyone. A very good evening to all true aspirants who all are live in the session. A very good evening. Yes, in the last previous class we have discussed the most important questions concept on the mechanical ventilator, where I have discussed completely on the types of the respiratory failure, that is the type 1, type 2, type 3, type 4 respiratory failure. I have explained the content, what how much necessary for your competitive exams. Then we have discussed the mode of the ventilation, where we have discussed all CPAP, BiPAP, PEEP, pressure support ventilation, synchronized intermittent mandatory ventilation, okay, assisted controlled mode ventilation, and controlled mandatory ventilation. We have discussed in detail in the last class, right? So most of the scenario based questions, clinical based questions, we have discussed in the last class. So one more part will come on the mechanical ventilator. That is the part two of the mechanical ventilator. So that will be uh, tomorrow morning. That class will be come in front of you people, right? So now in the today's session, as a part of the rapid revision, so some more syllabus left in your rapid revision session. So I'm going to cover those syllabus in the today's session. So completely be involved in the comment box, right? So whatever the question I am trying to ask, so please be response to every question, whether it may be a correct, whether it may be a wrong. Okay. So yes, before going to the main class, here is a beautiful motivational quote for you people. Stay focused, students. This is the time to completely stay focused and having the attitude of the never give up. So we have studied a lot of the things since from the last 6 months, 1 year, 1.5 year. You are completely giving your time towards the study. You know everything. Believe me, you are scoring the 50 to 60 marks in the master nursing classes or test series. Definitely your marks will strike at least 99 percentile. Okay, it will strike in the main exam at least 99 percentile. You people will definitely strike. Believe me, because we are keeping the question paper at the level of the hard, so you people will getting the at least 60 question answer correct means, so definitely it will work. Okay, so yes, so all updated thing, whatever you want to know on the questions we have already thrown in front of you people, right, as a form of the test series. Right, so here is a beautiful announcement. Today is the Sunday, all of you know that, and we are having the all India Sunday free Norcet 8 exams, right? So this is a completely free for all the aspirants. So what you have to do is to download the master nursing classes. Link I have given in the description box and in the comment box. So at the end of the class, do download the master nursing classes. This exam will be live till 7:30 p.m. Okay, it is started in the morning 6 a.m. till 11 p.m. it will be there. Okay, so at the 11:30 p.m. we will announce the all India rank in our official WhatsApp group and Telegram group. Okay, so everywhere in the all online platforms, right? So yes, to download the master nursing classes, you can directly search as a master nursing classes in your Google Play Store, or you can download by the link I have given in the comment box and in the description box both, right? So we'll start the today's class without wasting the time. If you want to know where you are standing among the all India actual aspirants, so what is your rank you want to know means, so just download the master nursing class app and attend the free Sunday test. So you will be knowing that. Okay, right? So here is the first question and very important question. Which of the following is the most appropriate advanced airway device securing the airway in a patient requiring the mechanical ventilation? Okay, so the patient we have to put on the mechanical ventilation, and the question is asking like which one is the most appropriate advanced airway device. Okay, what it is asking? It is asking the advanced airway device, right? So, Bacho, all of you know that we are having the two types of the airway devices. One is a basic airway devices, and one more is the advanced airway devices. Okay, so in the airways, we are having the two types, right? One is the basic, and another one is the advanced. Okay, so in the advanced, we are having the two types. One is the endotracheal tube, another one is the tracheostomy tube. And in the basics, we are having the S laryngeal mask airway, oropharyngeal airway, nasopharyngeal airway. Okay, so these all are the basic airways, right? So we will keep these things above the glottis, and these things goes below the glottis, right? So this is the classification of the airway in very basic, right? So the question is asking which one among the given is the advanced airway, right? So laryngeal mask airway is the basic airway, oropharyngeal airway is the basic airway, and nasopharyngeal airway is the basic airway. Okay, only one option we are having is the that is the ET tube is the yes the advanced airway. It's very important. So you people will study regarding the advanced airway again in the CPR questions. Okay. So what is the respiratory rate we have to give during the CPR if advanced airway in place? Like these questions will come. So we will discuss those things also in the upcoming classes, right? So remember, advanced airway means two airways we are having. One is the endotracheal tube, another one is the tracheostomy tube. Okay, so rest all are considered under the basic airways. So identify the device. Already in our WhatsApp group quiz session, our beams are already discussed these questions, right? So image based questions. So I am describing the function of the every part here because it's a very important concept and it is striking in the every exam. So I want to describe it in very sweet and short manner that is much necessary for your exams, right? Okay. So yes, almost all you people have given the answer. The name of the device is endotracheal tube, right? So here first, I will start with a very distal part. So this is a proximal part, and this one is the distal part, right? Completely at the end of the distal, we are having the one opening. So that is called as the ET tube bevel. Okay, ET tube bevel. Remember one MCQ. It will comes when we place the endotracheal tube inside the trachea, the ET tube bevel should face which side? Option A, right side. Option B, left side. Option C, straight. Option C, D, backward. So remember, always the bevel should face at the left side of the trachea. Okay, it should face over the left side of the trachea. Very important. Again, one more hole we are having here is the Murphy's eye hole. What we call this one is the we call this one as the Murphy's eye hole. What is the use of the Murphy's eye hole? Means if any obstruction in the bevel, so we can use this Murphy's eye hole for the suctioning purpose and to deliver the oxygen. Okay, very important. Remember the patient airway is obstructed, so we intubated the patient, and now the airway is open because of the ET tube. Okay, airway means now is the ET tube. If in case any obstruction, which is means whatever the secretions, the very thick scutums which obstructed the bowel means again airway will obstruct. So if in case the primary hole is obstructed means we have the another one hole from where the respiration happens. So that is the Murphy's eye hole. So that is the secondary hole. Very important. The purpose is to if primary hole obstructed, so we can use that one for the oxygen delivery purpose and the suction purpose. So that is the primary use of the Murphy's eye. So it will be asked in the exam. Very important. Then I will comes to the bevel. Sorry. Then I will comes to the ET tube cuff. So students, ET tube we will study two types basically. One is the cuffed ET tube and another one is the uncuffed ET tube. Look at this one. This is the uncuffed ET tube. So there is very important point all you people have to know that if the child is less than 8 years, If the child is less than 8 years, we will use uncuffed ET tube. And if the child is more than 8 years, we will use the cuffed endotracheal tube. This age criteria also people have to remember here. It's most important to everyone, right? So let me go to the function of this cuff. Function of this particular cuff. The question will come in this session only regarding the function of the cuff. I will describe the entire function of the cuff there because it's very, very important and it is very confusing to everyone. I will clear your doubt and I will make you such a complete clarification on this particular function. So you people will never ever forget on that one. Okay. Yes. So now this is the cuff. So how to inflate this cuff? This is the inflation tube here. This is the what it is coming. It's an inflation tube which will be connected with the cuff, right? It will be connected with the cuff. So we will take a 10 ml syringe and we will aspirate the air in the 10 ml syringe and we'll put the 10 ml air. Okay, very, very importantly, that is the 10 ml air we need to put inside the this cuff to inflate this cuff. Okay, very important. And cuff inflation should be always below the glottis, okay, and always below the vocal cord. Most important. If you are inflating the cuff above the vocal cord, means it will damage us the larynx, sound box, and there may be a option damage to the all nerves of the larynx. Also, the chance is there. So remember, always the cuff inflation should be done when the ET tube completely went in its place and it should be always below the vocal cord, right? So it's the most important all you people have to know. Okay, so are you able to see one mark here, this black color mark here? So this black color mark, it indicates it is below the vocal cord. Okay, this is the vocal cord guide. Okay, it's an vocal cord guide. So if this black mark is below the our vocal cord, means our entire bevel and Murphy size is below the vocal cord, so we can inflate cuff now. Okay, so this black means mark is the vocal cord guide. Okay, so it's very, very important. So then comes the uh, this curve of the ET tube. So this curve of the ET tube, so ET tube is not straight like this. Are you able to see in the image? ET tube is not like this. ET tube is like this. So this curve we call as on the Maglis curve of the ET tube. What we call this one? We call this one as the Maglis curve of the ET tube, and its curve is the 140 mm is the its curvature. Okay, so very, very important. The how much the curvature of the this particular Maglis curve is, that's the 140 mm. 140 mm is the correct answer for this one. Okay, and this particular part is called as the pilot balloon. Okay, so we will use this pilot balloon to describe and to say how the air is, sorry, whether the cuff is inflated or deflated like this. Okay, so it is having the single way loaded spring valve. Okay, so it's having the single way loaded spring valve, means we can insert the air inside, right? And if air will not come automatically, okay, the air will not come automatically back because it is having the single way loaded spring valve. Okay, if you want to remove the air, again you have to need to insert the syringe and aspirate the air. It's most important. Remember bacho, never ever put normal saline to inflate this balloon. Why? Because if accidentally this particular cuff rupture, means the fluid will go into the lung, and if fluid will go into the lung, means what we call that one is the aspiration will happens. Okay, so that means leads to the aspirational pneumonitis and dangerous complications will arise. Most important and very important, never ever put the normal saline in the cuff. And what we have to use? We have to use the air. Okay, we are using the air of the 10 ml. Yes, I will tell the cuff pressure also. Don't worry, everything will be clear in front of you people when the class will be ending today, right? So yes, that is the simple and very important thing. And this is what we call as the adapter. Okay, so it's having the standard size of the 15 mm. Okay, so in range it's on 14 to 15 mm. So single best answer is the 15 mm adapter. So for this 15 mm adapter, the 22 mm ventilator circuit will come and connect. So that is the very, very important line. And here we are having the a blue color line. So this blue color line is called as the radio opaque line. Okay, so that is what we call radio opaque line. So we use that one for the confirming the placement of the our ET tube. It's very important. And remember, the cuffed ET tube is used in, yes, cuffed ET tube is used in adults and uncuffed ET tube is used in children. So hope the concept and question is clear, and advanced and basic areas are clear to you people. It's very basic, and in the prelims the basic questions will come. Okay, so here is the next question. Please do read the question. I am waiting for your answers in the comment box. So fast do comment for the every question. I told in the starting of the class only, completely be involved in the class. Okay. So the next question is, what is the most commonly used laryngoscope blade for an intubation in adults? Okay, in adults. Yes, in adults, which one we have to use? Option A, Miller blade. Option B, Macintosh blade. Option C, the Williamson's blade. And option D is the Cormac blade. So, which is most commonly used laryngoscope blade in the intubation of the adult patient. So, on this one, the image based question also it will come. So, I will show that one. Okay. So, the Miller blade is the straight blade. So, we can use this one is in the children's. Okay. And Macintosh blade is the curve blade. We can use this one is in the adults. Okay. So very importantly, look at the images. This is the a curved blade, right? So this curved, okay, I can say this one is in the curved. Okay, that is the Macintosh, right? It's in C, it's in curved. So this is the Macintosh blade. So we can use this Macintosh blade in the adults, right? So these are the Miller blades. Okay, make a double L and which is completely straight, right? So there is the Miller blades. So these Miller blades we can use in the children's. Okay, very important, bacho. It's in very important. So Miller blade are the straight. So how to remember? Here is the C, which is having the curve. Here is the double L, so which is having the straight. So the straight blades are Miller blades, which is used in the children's, and the curved blades are the Macintosh blades, which is used in the adults. So our question is here. Okay, laryngoscope blade for the intubation in the adults is the our Macintosh blade is the correct answer. Okay. So remember, for intubation in the children's less than 8 year, we have to use the laryngoscope blade, that is the Macintosh, and uncuffed ET tube. Right? Let me repeat. For intubation in the children's, we have to use the Miller laryngoscope blade and uncuffed ET tube. If you want to do intubation in the adults, use the Macintosh laryngoscope blade and a cuffed ET tube. Very important, right? So for the, let me clarify. Okay, so 1 second, please. Yes, for intubation, simple. Okay, in children's and in the adults. Okay, so the laryngoscope blade you should using is the Miller one. Okay, and here the laryngoscope blade we are using in the adults is the Macintosh one. Okay, so here the ET tube we are using is the ET tube in the children's, that is the uncuffed. Endotracheal tube here using in the adult is the cuffed. Very important. Okay, so this is the very basic all you people have to know. I hope it's completely clear to you people. And identify this image. Identify this one. I'm waiting for your response in the comment box. Fatapat do comment. Right. This is the video laryngoscope device. What is this one? We call in a short, that's the VLD. That is the video laryngoscope device. So primarily laryngoscope is used to visualize the vocal cord. Why we are using the laryngoscope? To visualize the larynx and vocal cord during the intubation. Okay, so whatever we studied here, so these are the just a laryngoscope blade. Okay, this is the laryngoscope handle. We used to attach this blade here, and we used to use for the visualization of the larynx to easily insert the endotracheal tube, right? So if in case you are working in a very high uh, infrastructure hospitals, so there you people can see these kind of the devices. So these are the video laryngoscope devices, so we can easily see the a complete video of the larynx during the insertion of the ET tube. So it will make the ET tube insertion very easy. Okay, so that is the very important thing. Image based questions, it may strikes in your exams. Okay, it may strikes in your exams, right? So here is the next question. Right, the simple question, very important question. I'm waiting for your answers in the comment box. So for do comment for the this particular question. Right, which of the following is the recommended endotracheal tube size for an full term neonate of more than 37 week of the gestation? They have given age also. Okay, and they said it's a full term neonate. Option A is telling 2 mm. Option B is telling 2.5 mm. Option C is telling it's in 3 mm. Option D is telling yes 3.5 mm. When we talk about the neonatal ET tube size, here we are having the different types of the ET tube weight, according to the weight and according to the gestational age. One time question came to determine the size of the neonatal ET tube. Which of the following factors is going to matter? So option A they given weight, option D they given the, option C they given the gestational age, and option D they given the A and C both correct. Yes, the both A and C both correct, because to determine the ET tube size, the weight is also we can use, and we can use this one based on the gestational age. Okay, so here in our option they have given the 37 week of the gestation. So 37 week of the gestation belongs between the 34 to 38. So in the full term newborn, the best ET tube size we have to use is the, that is the 3.5 mm. So our answer is here. The correct answer is here. That is the 3.5 mm. Hope it's clear to you people, right? Yes, I think it's clear to you people. Let me read a chart again, and it is very important chart. Okay, so it's most important. Okay, very important. Take a screenshot of this one and revise immediately after class once again. Okay, if weight is below 1 kg, we call this is the very extremely low birth weight baby. What we call this one is in the extremely low birth weight baby. So for this extremely low birth weight, or the baby which born below the 28 week of the gestation, then now we can use the 2.5 mm size of the endotracheal tube. If the baby is 1 to 2 kg, so that is 3 mm. 2.5 if 2 to 3 kg, then if it's an age group of the 34 to 30 week of the 38 week of the gestation, the best one is the 3.5 mm. It's more than 3 kg or more than 38 week, so best one is the our 3.5 to 4 kg 4 mm. Okay, so the question will come. So the size of endotracheal tube in neonates, in range they will start with the 2.5, and the maximum size is the 4 mm. So the question will come, so which size ET tube we can use for the neonates? We can use the ET tube for the neonates, the 2.5 mm to the 4 mm. It's a very important question. Okay, so here they have particularly asked the question for the full term newborn of the 37 week of the gestation. So our answer is 3.5 mm. Okay, so here I think it's completely clear to you people. Okay, so here's the next question. Let's do read the question completely carefully, so till the end, and try to give your best answer in the comment box, right? So what is the approximate depth of insertion of an ET tube in a neonate weighing of the 3 kg? Okay, so the neonate weight is 3 kg. Yes, the neonate weight is 3 kg, how much depth we have to insert the endotracheal tube, depth of insertion of each tube in the neonate. It's a very, very important and it's a formula based questions. So I will say the very easy formula so you people will understand that one very easily. Okay. So now I want your answer in the comment box. So do put off a comment for the answer. The neonate weight is 3 kg. How much depth you will insert the ET tube here? Yes, that is the 9 centimeter we have to insert the ET tube depth. So here is the formula. Look at the formula. It's a very, very important. Take a screenshot. There is the tube length. The depth of insertion of the ET tube is typically based on the infant's weight. Okay. So the depth of insertion is not depend on the gestational age. Look at me. What I said there, that is the size of the ET tube is depend on the gestational age and weight of the infant. But insertion depth of the insertion is only depend on the weight of the infant. It's not depend on the gestational age. Are you people clear? To determine and to say the size, we use both gestational age and weight. To determine the depth of insertion, we will use only the infant's weight. Okay, that's the final answer. Okay, so here is the very, very important point. So depth of insertion is equal to 6 plus weight in kg. Here our bacha is 3 kg. So depth of insertion is equal to 6 plus weight in kg. Okay, 6 is the 6 I am keeping and weight in kg is the 3 I am keeping here. So 6 plus 3 is the 9 centimeter depth we have to insert at the child's, in the neonate. Okay, very, very important. So for example, also I have given here, so for 2 kg neonate, okay, tube should be inserted 8 centimeter. Okay, 8 centimeter from the our lip, or we can say from the incisor teeth to insert the ET tube. Okay, so insert the trachea. So hope it's clear. And remember the formula, depth of insertion is equal to 6 plus weight in kg. So that gives our depth of insertion in the centimeters. Okay, hope it's clear to everyone. Right, here is the next and very, very important question. Next and very, very important question. What is the recommended depth of ET tube insertion in an adult patient? In an adult patient, a recommended depth of the ET tube insertion. It's in standard values says that the ET tube should be inserted till the 22 centimeter from the teeth in the adult male and 20 to 21 centimeter in the adult female. Okay, so if you want a range, just a second, I'm changing the pen color. Yes, so if you want a range, so what is the recommended depth of insertion of the ET tube in an adult patient? They have asked. So always consider as the adult male. Okay, so always whenever the question will comes like this, if they are not specifying, you have to go for the adult male only. Okay, so this is the very basic fundamental, right? So here is the question. It's asking related to the depth of insertion in the adult patient. Previously, what we have discussed in the neonate, that is the 6 plus weight in kg. Okay, so but here we are having the standard. If the question comes for the adult male, that is the 22 centimeter, and if the patient comes for the adult question comes for the adult female, that is the 21 centimeter. So here now we have to choose the answer for the adult male. So the correct answer here is this one. 22 to 23 centimeter we have to insert the endotracheal tube inside the body. Okay, this 22 and 23 centimeter marking should be at the level of our teeth. Okay, it should be at the level of our teeth. So the correct answer for this particular question goes to the option B. Okay, so if they have mentioned the specifically female patient means it will be going to the option A as the correct answer. Okay, so that is very much clear. Okay, now the answer is the option B for this one. Okay, so hope you people seen in the ET tube the size here. Okay, focus here. Here is the 22. Okay, so this much ET tube will be inside the body and this much ET tube will be outside the body. So this particular 22 at the level of the our teeth in the adult patient. Okay, very, very important. And whatever the size they have given here, they have mentioned here is the ID 8.0. It means the internal diameter of the endotracheal tube is the 8.0, and always remember each tube size will be said according to the internal diameter of the a particular tube. Remember. The size of the ET tube will be set according to the internal diameter of the ET tube. Why? Because we have to insert the suction inside. So based on the size of the ET tube internal diameter, we have to choose the size of the suction catheter. So that is the very important. So always the size of the ET tube will be determined by the internal diameter of the ET tube. Remember, and 8.0 is the used in the adult patient. Okay, this is the most commonly size used in the adult patient. Okay, if they are asking adult male, the 8.0 is the most common answer. So let me write again the very important points for you all. The size of the 82 in the adult patients, right? We have discussed all these things. Okay, so let me take a new slide and give you a correct particular size of the 82. Okay, you people will never ever forget. So do note this one. If they are asking the size of 82 with this particular mentioning words, so your answer would be like this. Okay, size of the 82 adult male, that is 8.0 mm. Okay, for adult female 7.0 mm. Overall most common in the adults. Okay, second point, overall most common adult size is the 7.5 mm. Okay, so focus in the question, the size of the tube. If they are asking the adult male, your answer would be 8.0 mm. So adult female, that is the 7.5 mm. Overall most common is the in adults, so that is the 7.5 mm. Again, the best and most important answer. Okay, so here is the next question on the 82. We will discuss all the questions on the 82, then we will go for the tracheostomy, then we will go for the suction, and we will close the today's session. Because in the last Norcet exam, all you people know that the 4 to 6 question came on the one particular procedure, that is the 82 size, suction, okay, everything. So we will discuss those things. Don't worry, I will discuss entire thing before going to your main exams. That is most important to secure a position in the prelims exam and to get the rank in the mains exam, right? Right, the question is very simple. What is the primary purpose of the cuff? I told I will discuss the question on the cuff. Okay, so what is the primary purpose of the cuff of the ET2? Okay, so in the option they have given to prevent the aspiration of the gastric content. Option B, to secure the tube in place. Option C, to create a seal within the trachea to ensure the effective ventilation. And option D, to facilitate the easy removal of the tube. So it looks all are correct answer. Now you people have to choose the one best answer that is actually describing the function of the cuff in the ET tube. Yes, I'm waiting for your answer. So many of you are commenting as in to prevent the aspiration. It's not in prevent the aspiration. This is the second best answer is the prevent the aspiration. The second best answer is the to prevent the aspiration. The main purpose of the ET tube cuff is to create the seal within the trachea and to ensure the effective ventilation. So that is the very important. Okay, so if we are inserting the tracheostomy tube inside the ET tube inside the trachea, consider this is a trachea, and here we have inserted the endotracheal tube inside the trachea. Okay, so we have inserted the ET tube inside, means we are giving the positive pressure ventilation, means forcefully we are pushing the air inside the our trachea by the endotracheal tube. Okay, so here if these cuffs are not inflated, the air will come back. The air will come back. Okay, not like this. The air will come back like this. If it's going, air is going inside like this. and air will come back like this because of the resistance in the lung. So in order to prevent that one, so we have to inflate this particular cuff. So air will reach till the lungs. Okay. So it will reach till the lungs tissue. So this is the primary purpose to inflate the cuff. That is the to seal the trachea and to prevent the backflow of the air. So for the proper ventilation. Option C also telling the same to seal the trachea and ensure the effective ventilation. So this is the most important and the first best primary answer. That is the use of the EG tube. Okay, this class is for the clarity and this class is for to secure the a particular position in the prelims exam and to get the best rank in the mains exam. Okay, so do follow the instruction what I am saying. That is the most important to people. Okay, so answer C going to the correct answer. Yes, it is helpful for the securing the EG tube also, but the securing the ET tube, this is the least best method. So how we have to secure the ET tube? We have to secure the ET tube by using the tegaderm plaster. Okay, at the center of the mouth, we have to place the ET tube, not over the corner of the mouth. The previous guideline says the corner of the mouth. Now we have to secure the ET tube at the center of the mouth. It's very very important. Okay, so take a important golden point, right? Yes. So here is the next question for you all, right? The question is which of the following is a common method used to monitor and regulate the ET tube cup pressure. So to monitor and regulate the ET tube cup pressure, which one is the common method? Option A, visual inspection, just we will visualize. Option B, cuff manometer. Option C, the continuous auscultation, and option D, chest X-ray. So which one is the common method where we are using to assess the how much pressure is there in the each tube cup? So the best answer is the cuff manometer. Okay, this is the cuff manometer. This is the image of the cuff manometer. It's assessing how much pressure is there in this particular cuff. So this cuff manometer we have to attach over the this one-way loaded spring valve. Okay, so here it will tell us how much pressure is there inside this particular cup. Okay, the question will come how frequently we have to assess the cup pressure. Okay, so that is the Q8H. Every 8th hourly we have to assess the cuff pressure. Very very important. If this one is not an option, that is the every shift. In every shift of the nursing shift change, so that time we have to assess the cuff pressure very very importantly, and how much pressure we have to keep in the cuff. So this is the golden points I am telling, bacho. Very 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 important points. Okay, how much pressure we have to keep in this particular cuff. When it comes to the centimeter of H2, it is different one. When it comes to the of Hg, that is also different one. Okay, so here is the question that tells a particular clarity about the cuff pressure. So I will discuss this question. Okay, that will deal with your cuff pressure of this ET2. Okay, so the question is what is the recommended range of maintaining the cuff pressure and ET2 in ET2 cuff? So how much pressure we have to maintain and how much which is actually recommended. So option A is 20 to 25, B is 25 to 30, C is 35 to 40, D is 30 to 40. So I want your best answer. Yes, I want your best answer. Fatapat do comment in the comment box. Very, very good, bacho. So that is how the master nursing classes students acts like a champions. Okay, so this is the correct answer. When it comes to the of Hg, so the best answer is the 20 to 25 of Hg. We have to keep the cuff pressure in this particular cuff. Okay, so when it comes to the centimeter of H2O, it's in the 25 to 30 centimeter of H2O. This is also a correct answer. Okay, so 25 to 30 centimeter of H2O or the 20 to 25 of Hg is the a normal cuff pressure we have to maintain here. So the one question will come, if the cuff pressure is more, means what happens? So the simple thing it happens here, that is the tracheomalacia and the necrosis and granuloma over the site of cuff inflation. So what I said, this is the trachea, right? Let me take with another pen color so it will be clear for you. Okay, so this is the trachea. this side, and here this side. This is the trachea, right? And here it is having the arterial supply in the trachea. Okay, here it is having the arterial supply in the trachea. So here is our ET tube. Here is our ET tube, and we inflated this ET tube like this, right? So if it's okay, 20 to 25 mm of Hg pressure is there, that's okay. Or the 25 to 30 centimeter of H2 pressure is there, that is also okay. If this cup pressure is very more, means it will create the pressure on the trachea, right? It will create the pressure on the trachea. Now this arterial supply and the blood supply will get compromised here, means the blood supply will get interrupted here, the blood supply will not happen. Now this particular place becomes soft. This particular place becomes soft. In the medical terminology, if something is getting soft means we call this one as in the Malacia. So what is getting soft is here. Here the trachea becomes soft. So we call this one as in the Malacia is the complication which happens if the more cup pressure we are keeping. Means we are keeping the more cup pressure means what happens? The tracheomalacia happens. It's very, very important, bacho. If in case the cup pressure is low means there is chance of the air leak. Okay, air will leak back, and if there is the air leak, this cup pressure is low means the above secreted secretions it will go into the lungs, so chance of the aspiration also there. Yes, quickly revise. The normal cup pressure is the 20 to 25 mm of Hg or 25 to 30 centimeter of H2. If more cup pressure, there is chance of the tracheomalacia, and that particular area become necrosed. That is what we call as the granulomatous necrosis of the trachea. And most importantly, so if there is less cuff pressure, there is risk of the air leak and the aspiration both. Okay, so it's a very, very important concept. Only people have to know, understand, and give the best answer in your particular exams. Okay, hope the concept is clear, and this particular concept also very much clear for you people, right? So here is the next question in front of you people. So do fatafat read the question and try to give the best answer in the comment box. Okay. So what is the recommended position for the patient during the ET tube insertion? While during the insertion of the ET tube, so what is the recommended pressure we have to maintain here? Yes. So what is the recommended pressure we have to maintain during the insertion of the, sorry, what is the recommended position we have to maintain during the insertion of the ET tube? Right? Option is supine position. No. Supine position only we are keeping means there is increases the chance of the aspiration also, and it will not give a clear airway. So to insert the endotracheal tube, the airway should be straight. Okay. So the airway should be straight. So for that one, we have to give the a snipping position, and almost all people given the answer. The question will come how we have to give the snipping position. Means atlantoaxial joint slightly elevate and cervical spine flexion. Okay, so cervical spine we have to flex and atlantoaxial joint we have to slightly elevate. Then we are able to give the a snipping position. Okay, so here is the image based questions on the snipping positions. So that may comes in your exams because it's one very, very important. Look at this one. So this is the flexion of the cervical spine. Okay, so flexion of the cervical spine and extension of the atlanto-occipital joint or atlanto-axial joint we have to accept what we can say elevate. Okay, so extension of this particular joint and flexion of the cervical spine, so it will gives a clear straight airway, so we can easily insert the endotracheal tube into the trachea. Okay, so this is the in a normal patients. Okay, without any obesity, a normal patient comes to the emergency department. Now I want to insert the ET tube means I will give the snipping portion and I will insert the ET tube. Consider if the patient is very heavy and obese. Okay, so if it comes to the our particular emergency department, so now which position we have to give is the, yes, the position name is the ramping position. Okay, we have to give. So in which patient or the population is the ramping position is most commonly used during the ET tube intubation, means in the patient of the obesity. So this is the very, very important. The ramping position means like this one. Okay, so we call this one also as the rump position. RUMP rump or the ramping position. So this is to insert the ET tube in the obese patient. Okay, to insert the ET tube in the obese patient. Very, very important. The position to insert the ET tube in the obese patient is the ramping position, and the normally we have to use the which position to insert the ET tube? That is the snipping position. Snipping position. Very, very important and most important. Okay. So now identify the device which is shown in front of you people. So proper to identify the device which is shown in front of you people. So because it is a very, very important device, every alternative examiner is throwing a question on this particular device and the trachea dilating. Okay. So yes. So what is this device? So please do comment in the comment box. I'm waiting for your answers. Yes, I'm waiting for your answers. So do comment in the comment box. Yes. Anyone want to answer फटाफट? Yes, very nice of you all. Okay. So this is the the device name is the Magel's forceps. So what we call this one is the Magel's forceps. So this one everyone will identify and everyone will give answer as a correct answer for the Magel's forceps. But the examiner will ask the two very, very important purpose of this Magel's forceps. One is we will use this Magel's forceps whenever there is a upper airway obstruction with some external foreign body like a coin, like some seed. If it is obstructed the upper airway, so we have to go for the first for the Hamlich maneuver. And whenever the that particular object which is obstructing the upper airway is visible, okay, the upper airway which is where the particular obstructed object is visible, then we have to use this Magel's forceps to remove that particular upper airway obstructed object. Okay, so one purpose. And another most important purpose of the Magel's forceps is in the difficult intubation, we are trying to insert the ET tube inside the trachea. It's not going. Okay, in the difficult intubation, we have to hold the ET tube with the help of this Magel's forceps, and we'll insert the ET tube inside. So Magel's forceps is very much important for the two things. One is to remove the visible object from the upper airway obstruction, and another one is to insert the endotracheal tube in the difficult intubation. Okay, so I think it's clear for you all, and the question will come on the Magel's forceps. Very, very important. And one more, the confusing and a similar object which will comes in your object. It may comes in your exams. So yes, do comment for the particular question here. What I am showing here is this both are same? No. Look at the end of this particular one. Magel's forceps. Okay. Look at the end of this one. Yes. This is the image of the. This is the image of the jitter forceps. Okay. Very, very important. So we use this one to get the sterile article from the our wherever we are placing the articles in the some what we can say Sidex solution. From the Sidex solutions, we have to take the articles, means we use this jitter forceps and we'll take out the articles. Okay, so that is the very important use of the jitter forceps. And in clinical settings, more users are there. So most importantly, one we have to remember. Okay, so here is the next question. As part of what do comment for the answer. What is the recommended duration of the pre-oxygenation before ET tube intubation in a patient with a normal airway? Okay, or we can say not normal airway, in a patient with a difficult airway you consider. Okay, so yes, it's not normal airway. So in a patient with a difficult airway, we're going to give the pre-oxygenation before the ET tube intubation. The two questions will come in front of you in the exams. All people have to notice is when actually examiner asking. If the examiner asking the pre-oxygenation before the suctioning, of the ET tube, if the examiner asking what is the duration of the pre-oxygenation before suctioning, the pre-oxygenation is the 1 full minute. Okay, so before the suctioning, pre-oxygenation should be done for the 1 full minute, with the help of the amber bag. Okay, so where we are keeping the FiO2 to 100 percentage. Okay, so we are giving the 1 fill minute hyperoxygenation before doing the suction. But the question is not asking the before doing the suction. Still, we have not inserted the ET tube only. So before ET tube intubation, before the ET tube intubation. So what is the recommended duration of the pre-oxygenation? The examiner is asking the question. Yes, the answer is the complete 3 minutes of the pre-oxygenation should be done before doing the endotracheal tube intubation. So because if during the endotracheal tube intubation, if we get a delay also means the patient will maintain its saturation at least for the further 10 minutes. Okay, for further 10 minutes, he will maintain the proper saturation if we give a hyperoxygenation, pre-oxygenation before the 82 with a FiO2 again 100% for the complete 3 minutes. So that is the correct answer here. So hope it's clear to everyone. And here is the next and very important question in front of you people again. Yes. Which of the following is the most common muscle relaxant used during the intubation to facilitate the airway management? Okay, so we are doing the intubation here. What is the intubation? What is the extubation? Yes, inserting the ET tube is the intubation and removing the ET tube is the extubation. Where the removing the tracheostomy tube, we call that one as the decannulation. Okay, what we call that one? Yes, the removal of the tracheostomy tube is called as the decannulation, and removal of the ET tube we call as the extubation. Right? Very important point that will ask in the exam. What is extubation? Removal of the ET tube. What is the decannulation? Removal of the tracheostomy tube. Okay. So here, to intubate means to insert the ET tube. Before insertion of the ET tube, we have to give the a muscle relaxant and a IV anesthesia. That is the general anesthesia we have to give here. So the question is the most common muscle relaxant used before the ET tube insertion. The most common one is the succinylcholine is the most common one. Okay, this is the most common one, and the rocuronium is also an muscle relaxant. This is the new one we are using. Okay, but still the most common one in the hospital settings is the our C. So C is the correct answer. If this one is not an option, so the best answer is the rocuronium. Okay, so very important. So first best answer for the induction of the muscle relaxant before intubation. The first best answer is the succinylcholine. If this one is not an option, so go for the rocuronium. So that is the second best answer. Okay. So then comes to the whatever the anesthesia we have to use before intubation means we can use the most common one as the sodium thiopental is the most common anesthesia. It's not in muscle relaxant. The sodium thiopental is the anesthesia. Okay. So the midazolam is the old one. It's in midazolam previously regularly used for the intubation, but this one is now outdated. So midazolam may will not for use for the induction of the anesthesia in the intubation. Okay. So midazolam was used very long back days. Okay. So then comes to the propofol. So propofol also we will use for the induction of the anesthesia. The first best answer for the induction of the anesthesia before intubation is the, if the examiner asking the question, the most common anesthetic agent used for the intubation is the, that is our sodium thiopental. If this one is not there in option, the propofol is the second best option. Okay, so one time the examiner asked the MCQ on the propofol drug. Okay, that is the image based question he will directly ask because it is having some different characteristics of its consistency. Okay, in its consistency which looks like a milk. Okay, anyone can identify this one as in the propofol. Okay, so this is a propofol which looks like a very white and which is looks like a milk. So we can use this one as in the anesthesia. Okay, anesthesia, very important. We will give this one in the intravenous route. Okay, very important. Then the best one is the, our always best anesthesia is the sodium thiopental. So that one is not there in option. The propofol will go the second best and very important answer. Okay, so Sellick maneuver already I have discussed in the previous questions. of the rapid revision session. Again, to rapidly revise within a 30 second. I don't want to waste too much time because it's an already discussed question for you. Okay. How is Sellick maneuver performed during the endotracheal tube intubation? Okay. How is Sellick maneuver is performed during the endotracheal tube intubation? I want your answer in the comment box. So do fatafat give the best answer for this one. How we have to do the Sellick maneuver? Already discussed the question, bacho. So don't choose the wrong one. So try to choose the right answer. Okay. Option B, applying the pressure on the required cartilage to occlude the esophagus. Yes. So this is the main purpose of the Sellick maneuver, bacho. So we have to pressure on the cricoid cartilage. So that is what the Sellick maneuver is also called as the cricoid maneuver. Okay. So Sellick maneuver is also called as the cricoid maneuver, where we have to put the pressure with the help of the two fingers. One is thumb finger and one is the index finger. So you have to place on the required cartilage and push it back. Okay, so it will blocks the esophagus during the intubation. If that this particular our ET to be irritating the posterior pharynx means there is chance of the vomit is there. So in the snipping position, vomiting is coming means it will easily go into the trachea. So in order to prevent that one, we have to give the cricoid pressure or we have to perform the Sellick maneuver. So it will blocks the esophagus. If vomit also coming means it will not come to the trachea. Okay. So that is the reason. Very important. By applying the pressure on the cricoid cartilage to occlude the esophagus is the correct answer to for the Sellick maneuver. So it's very important. So option D, applying the pressure on the upper part also, upper part of the trachea, it's a not correct one. Then C, it's by performing the chin lift. This is also not correct one. Then option D, by pressure over the lower jaw to secure the airway. This is also not correct answer. Okay. So the correct answer is option E, by applying the pressure on the cricoid cartilage. Okay. So this is going to be a very important and correct answer, right? So here is the next question. So do you read the question correctly, properly till the end? So already birth maneuver or the birth technique. This burp also already we have discussed. So one more time rapid revision because we are discussing the intubation. So it's a part of the intubation. Okay. So what is the purpose of the burp maneuver during the ET tube insertion? So during the ET tube insertion, what is the purpose of the burp maneuver? So burp is here the we have to again put the pressure. There is the backward, upward, right side pressure. Okay. The burp stand here is the B for backward, U for upward, R for rightward, P for pressure. Okay. So burp maneuver during the ET tube insertion is done for the to visualization of the vocal cord. Okay. So optimum visualization of the vocal cord during the intubation. So that is going to be a correct answer. Okay. If you are performing the burp maneuver, very important. So then comes to the next question. Right. Next very important question. So after placing an endotracheal tube, you have already placed the endotracheal tube. You are auscultating the chest. You are now auscultating the chest. You are keeping the stethoscope on the wall of the chest of the patient and you are auscultating now. And you hear a breathe sound only on the right side. Okay. So only you are hearing the breathe sound on the right side of the lung and left side of the lung is not hearable properly. Means the sound is not coming properly. So what is the most likely cause? So we have intubated the patient. I have connected the patient to the ventilator. Ventilator is pushing the air. Now I am auscultating the chest whether the air is going or not till the chest. Okay. So only right part of the chest is getting the sound of the breathing and the left part is not getting the sound of the breathing by the auscultation. Means the ET2 what we have inserted. So that is gone in the right bronchus. Okay. So let me clear a concept that is very much important for you all. Okay. So this is the trachea and this one is the right bronchus and this one is the left bronchus, right? So sir, why we have drawn like this means yes, it is like this only. So right bronchus is always wider and always it is easily something, it will go into the inside the right bronchus. Okay. And the left bronchus is always narrow and which is not, if anything comes here it will not easily go inside. So always in all procedure you people heard that give the left lateral position. Why left lateral means if something went inside means also it will not go into the bronchus because it's a narrow and which is not favorable for taking anything inside. Okay, so if you are inserted the each tube means it will go into the right side easily. If you have, as I told in the adult male, we have to insert the 22 centimeter. Consider if you have inserted the 26 centimeter of the ET tube, means the extra length of the ET tube is went inside, and the tube is went in only one particular bronchi, means this particular lung only which creates the sound, and the sound will not come in the this side lung. So here, what we have to do is the each tube is intubated and the chest here the breathe only on the right side means the tube is went only the right side. So we have to take back the tube and keep in a proper position. The question is, so what is the most likely cause it is asking? Yes, the cause is the tube is in the right main bronchus and almost all people have the chosen the correct answer. So this is the very much important scenario based and practical based questions. It may thrown in front of you people in the main exams. Okay. Yes, here is the next question. Which method can be used to confirm the placement of the ET tube? Okay, so this is always confusing to the students. So remember, bacho, to confirm the placement of the ET tube, the best method is the ETCO2, right? This is the first best method. Okay, so what is ETCO2, sir? At the end of the tidal volume means during the exhalation at the end how much the carbon dioxide is coming. So that is the EtCO2. So the normal EtCO2 level is 35 to 45 mm of Hg. So this is the normal EtCO2 pressure. If this much EtCO2 is coming means yes, the particular and from the lung only carbon dioxide will come. Okay, so even if the chest X-ray is an option, if the examiner asking the first method, the best method and confirmatory method of the placement of the ET tube is the our EtCO2 is the correct answer, and chest X-ray is the second best answer. It is the second best answer. Okay, so remember always, right? If the examiner is asking which is the radiological best method, radiological best method means the X-ray will go as the priority best answer. Okay, even if the EtCO2 in option, the examiner mentioned ET2 placement means the answer will go for the X-ray. If nothing will be asked, just they have asked the confirmatory method of the placement of the ET2. The answer is the EtCO2. Okay, so that is the correct and first best important answer, right? So here is the how we have to confirm the placement of the ET2. One is by the we can by doing the EtCO2 by the capnography, where it will comes to the 35 to 45 mmHg, like it will forms like waves like this. Okay, so against the time duration it will forms the waves in the our monitor. Okay, so how we have to do this one means, so this is the consider this one is the ET2 and this one is the end part of the ET2. Here we have to connect the ET2 EtCO2 detector. Okay, okay, if sound is breaking I will make a correction, don't worry. So that is the EtCO2 detector we have to connect here. So this EtCO2 detector is connected with our monitor. Okay, so in this monitor the EtCO2 level comes like this. Okay, so this is how we have to confirm the CO2 is coming out means the tip of the ET tube is in the lungs only. Okay, so this is the best confirmatory and first method of the assessing the our particular placement of the endotracheal tube. That is the EtCO2 is the correct answer. So if this one is not the if this EtCO2 is not an option means the second best answer is the chest X-ray, and by auscultation also we can confirm the placement by, as I told, if by both side of the lungs are inflating and the respirator sound is audible in the both side of the chest means yes. So the ET tube is in the proper place. Only one side of the chest is expanding and only one side of the chest is having the sound of the breathing means it gone behind the carina. Okay, so this particular point we call this one as in the carina. So here the right bronchus and left bronchus divided. So this particular point we call as in the carina. Okay, it's a very important. So the endotracheal tube should be more than 5 centimeter. Okay, it should be always above the carina. It should be 5 centimeter. Okay, remember that very important point. Let me draw a diagram and tell you people for the better confirmation purpose. Okay, so consider this one is in the trachea. Okay, this is the trachea, and here's the right bronchus, left bronchus, right? So this particular point we call as the carina, and consider this one as in the vocal cord, and this is the ET tube. Okay, so tip of the ET tube, it should be 2 centimeter to 2.5 centimeter below the vocal cord. Below, one second, please. 2 centimeter to 2.5 centimeter below the vocal cord. Okay, and this is the carina. The tip of the ET tube should be 5 centimeter above the vocal cord, right? So listen, 5 centimeter above the vocal cord. Very important. All people have to know this particular reading. The depth of the ET tube after insertion. When we see in the X-ray, it should be like this. Okay, it should be 2 centimeter below the vocal cord and 5 centimeter. Sorry, 5 centimeter above the carina, not vocal cord. It should be 5 centimeter above the carina. Okay, so this is the correct answer, right? So it is very important. It's very important for you people, right? So hope the concept and question is clear here, right? So always it should be 2 centimeter below the vocal cord and 5 centimeter above the carina. The tip of the ET tube should be like that. Okay. So here is the next question. The ideal position of an endotracheal tube should be approximately how many centimeters above the carina? So just we have discussed that is the 5 centimeter above the carina and 2 centimeter below the vocal cord, right? So 2 centimeter below the vocal cord and 5 centimeter above the carina. So this is the correct answer. Very important. All you people have to know this one, right? So these are the fact-based questions you have to say, right? I think it's completely clear to you people. And now just try to identify the images what I am showing in front of you people. Let's try to identify the devices what I am showing here. Yes, what do comment? Yes, the suction catheters, both are the suction catheters. Which one is the thumb pressure or thumb control suction catheters? Which are the plain suction catheters? Yes, option A is the thumb controlled suction catheters, and these are the plain suction catheters. Okay, so how to identify? Look at this one part. Here it's in completely plain, and here on this particular end we are having the thumb control hole. Okay, so if we are putting the thumb on that one, it will apply the suction. If we remove the thumb on from that one, it will reduce the pressure. Okay, these are the thumb pressure control section, and these are the plain control section. For to use this one, we have to connect this one for the anchor canal. Okay, so this is the anchor section catheter. So very important image based question for you people. So what is this? This is the anchor. Okay, so this is the anchor suction catheter, very important. So where this part will be connected to the suction machine and this part will be connected to the suction catheter. Okay. To this plain suction catheter it will get connected, and on this particular anchor, so here is the thumb control hole is there. So if we are putting the thumb here, so it will apply the suction. Okay, if we remove the thumb, it will release the suction. So that is the anchor suction catheter, how it works actually. Okay, so very important question, and we have discussed the most of that one, right? So here is the next question again in front of you all. So what is the recommended suction pressure for adults who is performing the suctioning of the airway? Okay, the question is very simple and very important question. Very important question. What is the recommended suction pressure for the adult? Okay, so when performing the suctioning of the airway, so you are performing the suctioning of the airway. So now what is the or recommended suction pressure? So option A, that is the 60 to 80 mm of Hg. Focus over the question what the examiner actually wants to ask. That is the in adults he is asking the question, right? The suction pressure in the adults. So option A is the 60 to 80. Option B is the 80 to 100. C is the 100 to 120. And option D is the 120 to 140 mm of Hg. So what is the correct answer? Fatafat do comment. I'm waiting for your answers. In the adults, the recommended suction pressure is the always 100 to 120 is the always best answer. Okay, 100 to 120 is the always best answer in a adult patient during the suctioning. So we have to keep the suction pressure at the 100 to 120 mm of Hg, and maximum is the 1